So thank you very much. It's a pleasure to be here, and I want to thank Dr. Salah for hosting me. It's a fantastic meeting, and I think that this morning we had a nice breakfast with the expert session, and we talked a lot about refractive IOLs and refractive surgery becoming the same as cataract surgery, and I think we brought up a lot of interesting points, so I'll share what I learned at the breakfast too. So financial disclosure, these are my consulting agreements. So I think of cataract surgery now as really refractive surgery in every patient. And I think that that's one of the things that I've really learned and evolved over the last few years is that now every single patient expects a wonderful outcome. And we were talking this morning about how the people are they're so picky. And I practice right outside Boston, and Bostonians tend to be extremely picky and very finicky. And Dr. Mohammed Hasni was next to me, and he said, Egyptians are the same way. So I learned that the Egyptians and Bostonians are very similar. So every single patient I think about astigmatism, not just those that I'm thinking about a toric IOL. So I think it's important to make sure we diagnose and manage it properly. When we actually look at all the patients that we see, this is Warren Hill's data, it's a lot more than we think. So when we're talking about astigmatism alone, about 50% of your cataract patients could benefit from a toric IOL. So it's much higher than the 15 to 20% that we had originally thought about over the last 2 decades. Fortunately now the companies do come in all sorts of powers, so all the way from a T2 in a lot of the parts of the world, we have T3 in the US, and goes all the way to a T9. A real easy rule of thumb to remember which T power to use is if you actually start with T3 at the corneal plane, you think of it as 1 diopter, 1.5, 2, 2.5, 3, 3.5, and 4. So that helps you march through T3 all the way to T9. If you're using a presbyopia correcting lens, I think it's very important to think about astigmatism. So if you have a low amount, I tend to just operate on the steep axis. But a higher amount, and higher being about 1.0 or above, I always tend to think about a toric IOL. In the States, we don't have a toric multifocal lens, and so if we are putting in a multifocal lens, we still have to treat the astigmatism, whether it's with the femtosecond laser or manually in an LRI. I think it's very important to make sure that you're concentrating and treating the astigmatism. I learned a lot from Jim Gills, who's a cataract surgeon that's probably very well known around the world, and we collaborated on a textbook on astigmatism. And I do think that astigmatism is something that's become more and more exciting because of all the things that we can do. So David really showed wonderful videos about the intraoperative aberrometer, and this really helps titrate even the smallest amounts. So I think coupling is a very important topic that we actually don't talk a lot about when we think about a limbal relaxing incision. And very briefly, coupling is defined as a steepening in the meridian 90 degrees away that's equivalent to the flattening induced by the incisions. So why that's important is that if you actually have a large limbal relaxing incision, you may induce a different type of coupling. So what I mean by that is oftentimes you want a 1-to-1 coupling ratio. So most corneal relaxing incisions have a 1-to-1 ratio, which means that you don't have any modification to the power, the spherical power of the IOL when you're making a limbal relaxing incision. However, if the coupling ratio is greater than 1, that means that flattening has occurred and you're creating more of a hyperopic shift overall. Conversely, if the coupling ratio is less than 1, you're actually indicating a steepening, and that creates a myopic shift. So here's some examples. So if a patient's spherical equivalent is hyperopic and you actually want a myopic effect, then you actually want a coupling goal that's greater than 1. So how do you accomplish that? So you can actually increase the coupling by either making a longer incision, so longer LRIs. You make transverse or arcuate incisions rather than radial. You have a larger optical zone, and you can make asymmetric incisions. All those things will increase the coupling ratio greater than 1. A good rule of thumb is if you're making a very long LRI, longer than 6 millimeters, you're going to add 1/3 of the power to the IOL. So for example, if you're covering 3 diopters of astigmatism, let's say you can't use a toric for whatever reason, and you're making it with an LRI, then you want to add 1/3 of that power, which is 1 diopter if you're correcting 3 diopters, and you add that to the power of the IOL. So instead of adding a 20 diopter IOL, you're going to add a 21 diopter IOL. If you actually want to do the other side, which is the patient's spherical equivalent is myopic and you want a hyperopic effect, that's a little bit harder, and you want the coupling ratio to be less than 1. Little trickier to do. The best way to do that, you actually make multiple pairs of short 1.5 to 2 millimeter arcs. And so that's a little bit more unusual. It's a little harder to do, but that's just something to keep in mind. When you do an LRI, lots of nomograms are out there available. Fortunately, Skip Nickerman has a wonderful one. Eric Donnenfeld has a good one. Lots and lots of different ones. There is a website called LRI made by AMO that's online, that's really helpful. And most of them have factors such as the age of the patient. You want to know the location, whether it's with the rule or against the rule, and the amount of astigmatism. There are two ways you can actually use a preset blade. Usually there are 600 microns, or you can have a variable depth based on the depth of the cornea at the location that you're actually going to make the LRI. And you can either use clock hours or degrees or millimeters. Everyone does it a little bit differently. My pearl number 2 is that I think besides astigmatism, I think about presbyopia correction now in every single cataract patient. So again, it's not just the patients that I'm thinking about whether or not they're going to have a multifocal or an accommodating lens. I think it's very, very important for all the patients, especially those, for example, that are myopic. So we've all encountered patients where if they were already a -3 preoperatively, if you don't counsel them and they end up plano, they're going to be very miserable if they lose that uncorrected near vision. So we've already learned that. But the other subset of patients are people whose spherical equivalent is myopia. So they may be plano, but they have cylinder. And those people also have pretty good uncorrected near vision preoperatively, and especially if they've had a myopic shift from the cataract. So in those patients, I think it's very important to at least bring up the options of the different types of IOLs. Everyone does it a little bit differently. For me, I always check the dominance of the eyes. And I know it sounds like it's not important, but I think that the reason why it is important is that none of the lenses are perfect. And I think that every lens, there are pros and cons of every lens. So the reason I check the eye dominance is I tend to operate on the non-dominant eye first if they have bilateral cataracts, even if it's not the more severe cataract. And that's because oftentimes I will recommend a multifocal lens for that patient if they have a healthy eye. And if I do that and that patient has great success with the multifocal, they're very happy, then I put it in the dominant eye and that's the end of the story. They're very happy. However, if they fall in the subset of patients that they're not happy with the multifocal, they either have glare, they have halos, they've lost a little bit of contrast sensitivity, then in their dominant eye, I have a choice. I could either put a monofocal lens, I could put an accommodating lens, and I find that with that combination, with both eyes open, they tend not to be bothered with the distance vision, with the glare and halos, because their dominant eye is not seeing those. And for their near vision, because both eyes are open when they're reading, the multifocal eye gives them sufficient near vision that they can do most tasks without reading glasses. If it's monovision, I tend to operate on the dominant eye first if they're myopic. And the reason is because in between the two eyes, then they will already have monovision. So they will have one distance emmetropic eye, hopefully, and they're living with their myopic eye before the surgery, and therefore they can tell me whether they like the monovision, and they can also tell me whether they want less monovision or more monovision. So that's a nice trick to have the in between the time. All right, so counseling, very, very important. I do think that this is something I learned from David Chang, was that when we use these lenses, you always have to tell patients that it's a compromise. So you always have to tell them that you're giving up something in order to get something. So with a multifocal lens, I tell them that they may give up a little bit of sharpness of vision. And oftentimes I'll give the analogy of high-def TV and regular TV. And I tell them, well, you remember before high-def TV was available, conventional TV was just fine. But high-def TV gives you a little bit more sharpness of detail, and that's a difference, that you're giving up high-def in order to have conventional TV. So it's not a perfect analogy, but at least people understand what they're giving up. In between the two eyes is when I can determine whether they're happy with that first lens. So if they're ecstatic with their first lens, again, very easy situation. But if they're not happy, then you have to decide what you want to do. And I usually don't proceed with the second eye until I know why they're unhappy with the first eye. So if they're unhappy, why are they unhappy? Is it the most common, which is residual refractive error, especially astigmatism? Is it the glare? Is it the contrast sensitivity? And if you can't make them happy, in our practice, we just reimburse the out-of-pocket costs. I think it's much better to reimburse them and make them happier. Somehow I think patients, if they're made whole financially, they seem to be less unhappy with their choice of their multifocal lens. And the third is, I think it's very important to be compulsive with every patient. So with topical surgery, we want the eye to look as if they never had surgery. And even if they have perfect vision, 20/20 uncorrected on post-op day 1, but they have a big subconjunctival hemorrhage, they're going to be very unhappy and they're going to think something went wrong, even though they see very well. And I think we've all had those types of patients. So I think it's really important to think about everything, the conjunctiva, the cornea, both the epithelium and the endothelium. I think it's a good idea to polish every capsule too. You don't want to leave a lot of strings in the back of the posterior capsule or the anterior capsule so that you're decreasing the risk of epithelial lens migration. So you want to decrease the risk of posterior capsular opacity. So I tend to polish in every patient that's receiving one of these special lenses, and especially if even in a regular lens, if they have a lot of material, I will go ahead and polish. I also found that since I chop as a technique, little fragments of lens material is always hiding in my paracentesis port, and also they can hide in the angle and underneath the iris, especially when they have a small iris for pseudoexfoliation or floppy iris syndrome. So I always tend to irrigate through the paracentesis to make sure I liberate any little chunks of lenses that may be hiding. So in summary, I think it's important to treat every patient like a refractive patient and to make sure you're choosing all the little details and focusing on all the little details. Thank you very much.